Thank you so much, Andrew, and thank you to everybody who has showed up today. My name is Elysée Nouvet. Our goals here are to present and discuss findings from a rapid global study completed just recently in May 2020 about critical care triage during this COVID-19 pandemic. And a few details before we get started. First, Dr. Strachan and I are speaking here on behalf of a larger team. So I just want to acknowledge that this is a project conducted in collaboration with researchers at Western McMaster University in Canada and the University of Turin in Italy, as well as in collaboration, as mentioned by Andrew, with the Humanitarian Healthcare Ethics Group, which is based out of McGill and McMaster University. The study received support from Western University, as well as the World Health Organization. And I'd like to extend a special thanks to Janice Carty at Western and Nina Gobat, as well as Yolanda Bayugo from the WHO for their help throughout this process. I do also need to acknowledge the incredible team of trainees that we had the honor of working with throughout this project. Their names are up on the screen, and they're a mix of master's, PhD, and undergrad students. And they jumped on board really quickly, just as the world was pretty uncertain. And really, this study would not have been possible at all without their incredible dedication. So thank you very much. We're going to get started, and here's the plan for the presentation. So first of all, we'll provide you with an overview of the study itself, what drew us to the topic, research questions, methods. Then we're going to get into a summary of key findings, and there is a 68-page report upon which this is based, so you're getting a taste of those findings. We're going to focus on findings in 3 areas, those related to providers' experiences and concerns related to critical care resource allocation in specific healthcare practices. So we heard a lot of support for triage plans and guidance, but also some significant concerns and skepticism about plans and guidelines. So we'll delve into those. The second set of findings is focused on patient care, and specifically, as the title of the webinar suggests, care to those individuals with life-threatening disease who may opt out of or be triaged out of critical care in scenarios during this pandemic where a healthcare system is overwhelmed to the point of not being able to operate along its normal triage guidelines. And the last set of findings will focus on communications. And here we're going to outline and unpack some of the key considerations we heard from participants when it comes to sharing critical care triage decision-making and implications with patients, families, and the wider community. So we'll have time, of course, at the end, and we're really looking forward to extending our thinking and dialogue with you with a question and answer period at the end. To get started, I wanted to bring you into our thinking and how we got started. So the premise for this study. Many of you might remember an article, it's certainly an article I will never forget, published in The Atlantic on March 11, 2020. It describes the situation in the Lombardy region of Italy and hospital teams there facing the need to make tough choices or impossible choices about which patients should be prioritized for beds and ventilation when facing life-threatening disease. New York City, France, Spain were not far behind, of course, and we know that this situation has extended to other countries such as Brazil as well, all despite being countries with surge capacity for ICU beds and staff. There are currently no proven treatments for seriously ill COVID-19 patients at risk of dying, and current best practices to maintain or improve the likelihood of their survival includes provision of oxygen, mechanical ventilation. These are some things that are not available everywhere. They require particular equipment, as we know, infrastructure, anesthesia in the case of intubation. And these also, of course, critically depend on staff with the knowledge and expertise to assess the need for and to apply and to monitor patient responses to interventions. So the capacity to safely provide critical care to highly infectious COVID-19 patients also depends, of course, on measures to limit viral transmission to those providing the care. So there's a lot of complexity already implicit within the provision of critical care during this pandemic for COVID. But the world is not unprepared. In theory, for pandemics, certainly every pandemic is different. Every place and population a pandemic hits is unique. But there's a lot of guidance at this point on how to optimize equity and fairness in the allocation of critical care resources in the event of there being a potential for shortages for those resources. Many countries have extensive firsthand experiences as well with epidemics. There's countless bioethics articles, regional, national, as well as international guidance documents on managing resource scarcity in pandemics, including for critical care. And of course, many of our colleagues, hopefully colleagues on this call, have experience firsthand with managing critical care scarcity on a daily basis. Unfortunately, this is the case in many countries. I'd like to just draw attention to a recent publication in May 2020. This article was published, a synthesis of European guidelines for pandemic triage for critical care. So our study had launched, but it was useful in terms of indicating several areas of consensus on what can and should be done to optimize patient care and also fair resource allocation should needs outweigh resources. So it looked at a bunch of the guidelines across Europe, and there certainly was consistency in these guidelines. So there was consistency in terms of recommendations for fair and transparent decision-making, consistency in terms of recommending patient or legal representative involvement in treatment choices, and also strong recommendations for preparation and provision of palliative care to those who would not receive life-saving interventions if you're in a state where you do need to limit life-saving interventions to more people than would normally be the case due to shortages. So we know a great deal, but what remains extremely obscure now, just as it was when we launched the study, are the ways in which recommendations and plans for allocating critical care are playing out in real time and in very diverse and evolving pandemic landscapes. We don't know how those already on or positioned to be on the front lines of patient care in this pandemic are experiencing guidance on what to do in terms of critical care resource allocation. And we were very much interested in this. We know that best practices are really meaningless if they're not supported by those in the position to implement those practices. Our research group is also a group that has been working for several years in the space of end-of-life care, both in high-income countries and in public health emergencies. And we know that until very recently, planning for palliative care needs in public health emergencies has been extremely limited. So in 2018, the World Health Organization published guidance for public health emergency preparedness, and that called for palliative care planning and provision. This was also echoed and reiterated in the SPHERE project guidelines published just last year. Still, we know, unfortunately, that end-of-life and non-life-saving care can be, and often is, sidelined in public health emergencies. So a key question in our minds as the WHO declared the pandemic in March 2020, and knowing that there already is a scarcity of critical care resources in many parts of the world going into this pandemic, a question in our mind was, what would be done for patients who might be triaged out of critical care in hospitals or in the community during this pandemic? We're also very interested in the question of communication. We know that there's been all sorts of headlines about the elderly being left abandoned to die, very dramatic images of refrigerated morgue trucks in New Jersey, New York State. And we know that these images and the way in which they're framed in the media could really break trust, increase fear, increase panic, even lead to violence in certain cases against facilities or healthcare providers. So we have rolled into the study attention as well to communication practices around the resource allocation, critical care resource allocation. I'll hand it over to you, Pat, to describe in more detail how we went about our study.
Thanks very much. I'm happy to be with all of you. I'm going to walk you through the methods that we used. The findings we're presenting today have been gathered in the context of a rapid qualitative study. We were 6 weeks from protocol development to completion of data collection, and the data collection occurred over 3.5 very intense weeks in April 2020. So essentially, our objectives were to build evidence that can inform governments and healthcare organizations in their development and implementation of realistic and socially and culturally sensitive COVID-19 triage and triage communication strategies, to clarify what individuals positioned to be on the front lines of healthcare delivery regarded as ethically crucial to the care and treatment of persons who would not be prioritized for critical care during this pandemic, and then ultimately to contribute to debate and discussion on the perceived benefits, difficulties, and contextual differences that need to be taken into account when we're sharing information about plans for triage of seriously ill patients, particularly in the case of resource scarcity issues. So data collection consisted of 52 in-depth, semi-structured interviews and 15 written responses. The interviews were conducted over the phone or using Zoom in 3 languages: Italian, French, or English. The written responses were collected via a Qualtrics platform, and we did purposive sampling across all 6 WHO regions. The eligibility criteria for participants were that they had to be individuals who were already positioned or going to be positioned to be involved in the implementation of critical care triage during the 2020 COVID-19 pandemic, and those who were caring for COVID patients with life-threatening illness. Maximum diversity in participants' position and expertise was sought so that we could understand perspectives of individuals who are routinely facing resource shortages, and through to those who, for such experiences, are less common. And with this diversity in mind, we simultaneously sought to gain balanced representation across the WHO regions, essentially gender, high income, low income, middle income countries, degrees of their experience and professional backgrounds of the participants. Now, on the left-hand side of the slide, you can see the questions that we asked participants. They were semi-structured interviews, so there was, of course, some digging into responses, but these framed the structure of the interview. So, is there a pandemic-specific plan for the allocation of critical care? Who should make triage decisions regarding critical care? What care was currently and what should be provided to patients who are triaged out of critical care? And then, should triage criteria and plans be shared transparently with patients, families, and the general population? And a little bit more about our participants. We had 67 participants, 52 interviews, 15 written responses, but of the 67 participants that contributed, 35 were physicians, 16 nurses, and the remaining were quite diverse, so included a hospital director, paramedics, a social worker, and 2 mental health professionals. 25 respondents identified as women and 42 as men. In total, 43 participants were working with COVID-19 patients in hospital or in a dedicated COVID-19 treatment center at the time of the interview. The remaining were working in community-based care practices, so community-based clinics, refugee camps, and home care. There's definitely an overrepresentation of those from high-income countries in our sample, and this reflects the pandemic at the time of our interview was putting a lot of pressure on systems, health systems in Europe and the Americas to an extent that had really not been seen at that point in most low-income countries. And of course, the situation has continued to evolve and become more global and severe. And so this also reflects the written responses. All but one were from low-income settings. And This infographic illustrates the stage of the pandemic being faced by the participants when they were interviewed. So as you can see, all the orange figures represent participants who spoke from the perspective of still being in the preparedness stage. The palest blue is showing us those who are in the early surge stages, with all the blues speaking from the experience of being in the middle of the pandemic. You will hear a number of dramatic differences that constitute the backdrop to critical care, triage, and care in this pandemic worldwide. For example, some countries have as few as 4 ICU beds. The highest intensity of care for respiratory distress will be the provision of oxygen. High-income countries in our sample described having several hospitals with dozens and sometimes even hundreds of ICU beds and infrastructure to transport patients to hospital with capacity when one is full. And while many high-income countries have struggled to outfit their healthcare professionals with adequate personal protective equipment, especially in the first few weeks of the pandemic, in many low-income countries, the PP situation is dire. We do have key findings that emerge out of a sample that includes high, low, and middle-income country participants, but certainly bear those differences in mind. And we'll be pulling them out further in the findings, and we'll also be happy to discuss those and their implications during the discussion and the question and answer period. And I'll turn this back over to Dr. Nouvet.
Thank you. Okay, so getting into the findings, that first category of findings, providers' views on plans for critical care triage in their context of practice. So here we were really asking people, what is the plan? Are there guidelines or are there committees? Who's involved in terms of determining if there's a shortage of critical care resources, who's going to be prioritized? And very importantly to us, does the plan strike those on the front lines as ethical and sufficient, and do they have any concerns? So what did we learn? First of all, a majority of the individuals with whom we spoke value advanced care systems planning, absolutely, as well as committees and guidance for scenarios where critical care needs outweigh resources. Reasons that were provided for that support echoed arguments in the pandemic preparedness and bioethics literature, mainly to support fair and consistent allocation of resources across hospitals and regions, with the possibility of there being kind of chaos and competition, if anything else, if there was that lack of consistency. Also to support a responsible use of limited resources. Now, this is particularly important in contexts of where there's kind of universal healthcare, and therefore there is a need to kind of be careful about the allocation to everyone in need. And then to alleviate the burden of resource allocation decision-making on healthcare providers. So participants described the burden related to triage decision-making when it came to critical care as the most potentially destabilizing element for their mental health during the pandemic. And so there was really this looking to committees removed from the bedside in most cases and guidance as a way to kind of anchor the already enormously stressful situations of working in a scenario where perhaps not everyone is getting the optimal care they would under normal circumstances. So a quote, that kind of concern about having the burden on your shoulders as a bedside provider was expressed by participants from low, middle, and high income countries. Here's one quote: if we leave it to them without guidelines, the providers, there will be a psychological and actually catastrophic psychological impact on them in the long run. I don't know how it can be compared. So on the one hand, we definitely heard strong support for committees and guidance, helping with difficult choices that providers would be, healthcare teams might face in terms of determining who has access to the ICU, or in low-income contexts, really, who even has access to a center, who has access to oxygen. On the other hand, many were not seeing planning and guidance for critical care triage in evidence in their workplace at the time of the interviews. And so this was quite interesting to us. 29 of 67 participants reported that in their workplace there were pandemic-specific guidelines in place to support critical care triage and decision-making. But the rest, 57%, knew of no pandemic-specific guidelines or guidance or committee in their workplace. So those who did, some had heard about triage guidelines, but even those who knew there were some in place reported a lack of clarity about their content, the origin, who had been at the table to develop these, the justification for different components in these, and the implications for practice in real time. Many were not sure, first of all, if who had been at the table to develop them. So that we got a statement from one who said these are guidelines being developed by who knows where. And some knew of guidelines but didn't understand them, sometimes because they were receiving these instructions on how to make their decision making embedded within a series of memos or emails that would have changing instructions or considerations over a series of days or weeks. Sometimes as well, the guidelines that they were provided for the allocation of resources and for the allocation of their time as providers of critical care didn't seem to make sense to the providers as well. So that raised some questions as well. So for example, this had to do with PPE even. We have somebody who talked about you could only use PPE when necessary in the community. And she's asking, or he's asking, we are officially given PPEs only if we are certain that we have a patient with suspect COVID symptoms. You understand that if I arrive at the patient's house and observe that there are symptoms, I don't have the PPE. So this was quite baffling to people. Like, how do you kind of navigate guidelines that don't necessarily make sense? One participant, in the absence of knowing where their institution was at with guidelines for critical care triage, was already expecting that these might not make sense and was ready to defy them. So they said, nobody will tell me to put an 80-year-old in good shape to a regular floor with morphine because he is not in the observations of that government or algorithm that should be followed. I am not going to put a tube in his throat and try, I am going to put a tube in his throat and try to save him, even though he is not in the algorithm. So in this case, this participant really was adamant that they would continue to exercise their practice, their clinical expertise, and put the patient in front of them before anyone else. And this kind of gets into the utilitarian reasoning. So we talked about the utilitarian reasoning with participants. This is a reasoning that kind of has emerged a lot in the media. It places the well-being of society or population as a whole above the well-being of individual patients. And therefore moves away from patient-centered care, but is common in terms of management of scarce resources in an emergency to optimize the benefit across the population, and it's often equated with lives saved. So most participants did expect and express agreement with application of utilitarian reasoning in high-income countries, but they were concerned. They were concerned that this would deny that it would be clinically unsound because two 72-year-olds are not the same, two 89-year-olds are not the same. Comorbidities don't mean the same thing in two patients. So you would still need that case-by-case assessment. There was worry about ageism or other forms of discrimination, for example, against people with disabilities. So naturalized ideas about benefit and who should be prioritized were being questioned. And certainly a sense that inequalities would persist. People with the resources would be able to circumvent any kinds of limits on care they would not be allowed to access by the rules. If you had the connections and the resources both in high-income countries and low-income countries, those inequalities would persist. We also have, so in terms of these inequities, this is definitely even more dramatic in our low and middle income country settings in many cases. We heard from many participants that plans and principles of a pandemic will not trump entrenched inequalities. These include, for example, norms in some settings that render a female head of household more dispensable than a male head of household because of the social and economic ramifications that ensue for a widow versus a widower. So as one participant noted, such favoring of men over women in their context of care would just happen. And they said, nobody will choose the man, it will just happen somehow. Somehow it'll happen. Even the woman will probably say, I don't need it, I'm doing fine. So the bottom line is that in most low-income countries, access to critical care was seen to be already very much cut with economic and social inequalities and is limited and dependent on one's ability to pay, with many stressing that the pandemic was not expected to change any of that. Major concerns were raised around PPE. One participant in a low-income country said they would be sleeping at the treatment center rather than risk contaminating their family and those on the public bus they used to go back and forth to work normally. The same participant explained that their current strategy for PPE was to wear extra trousers over their uniform because there was nothing else. And asked about the risk they ran for themselves and their family, the healthcare provider said in a resigned but committed voice, "I am a soldier. I am going to do anything for my country." Several participants from low-income countries commented that on the fact that the lack of PPE was going to be the key factor in terms of patient care. So one participant spoke of a patient at the beginning of the pandemic being simply locked up and apparently not even provided food in an abandoned kind of building. In the same country context, healthcare providers were being asked to purchase their own PPE. Anything they could find was cheap, the quality was dubious, and this participant was certain many would just not show up for work under current conditions, even if employed by the government. Not only because of the lack of PPE, but also with knowledge based on prior outbreaks that there would be no compensation to their families if they perished. The participant did not necessarily see this as the government's fault, but rather the reality of a health system with limited resources. It was of course not just the lack of PPE that limited patient care in low-income countries. Other needs mentioned included adequately trained staff to manage critical care delivery, ventilators, and oxygen cylinders. Age was a controversial consideration for critical care triage. There was a consensus across the board that age can never be used in isolation as a criteria for determining who can potentially benefit from intensive care. But using age was also not realistic to participants in settings where a high value is placed on the role of the elderly in society. So one participant, for example, noted that in their context of care, if there is a son and dad, both are sick, it is very much possible that the son will give the respirator to the dad. It's possible. We also heard another participant say that there simply were not many people over the age of 65 in their country. So to kind of develop any kind of guidelines that took into consideration age didn't make sense. Moreover, in that context, people rely on the elderly for blessings and advice, we were told. So what are the implications for practice of those findings? Well, here are a few. Any national and international guidance on critical care resource allocation during this pandemic will have to avoid assuming there can be any universally resonant logics or culturally acceptable approaches or criteria for that allocation. Guidelines are perceived by a majority as helpful across the globe, but this helpfulness does depend on the healthcare providers understanding those plans as flexible and seeing those plans as having been developed in a manner that is transparent and inclusive of those they see should be at the table. This is consistent with guidelines development literature. Access to resources or a lack of that access and existing inequalities form key determinants to critical care being provided. And if fairness is a goal and expectation, therefore, plans need to take into account those pre-existing inequities. A lot of what I've just described definitely applies to our kind of second entry point for the interview, which was asking what care was being provided to patients triaged out of critical care. So as you can imagine, resource shortages, inequalities, these all kind of are echoed back into the set of findings. So I won't spend time on those, but I want to highlight three main shortcomings that emerged from this question. First, with respect to addressing the patient's suffering at the end of life within COVID hospitals or COVID centers, there hasn't been home-based COVID care. Palliative care was described in only 19 of the 52 interviews as something offered and planned if someone is declining outside the ICU. The limited mention of palliative care, even though this term may not be the term used universally, was a concern to us. Those 19 individuals who mentioned palliative care, many described the provision of end-of-life care as focusing exclusively on symptom relief. some acknowledged that really there were serious limitations in terms of the provision of psychosocial care to patients, and this weighed heavily on them. There does seem to be some bereavement support, using phone calls in particular to families to keep them in touch with their loved ones inside. But that support to hospitalized patients is lacking overall, and this was stressed again and again. Palliative care for patients is not just about symptom relief. It has to address the social, psychological, and spiritual needs of patients. And because some participants were saying, we do palliative care, we'll do palliative care, and they would only describe symptom relief, it does kind of raise concerns about what is palliative care during this pandemic. Is there kind of a pandemic-specific palliative care that does not, that is actually more symptom relief? Also noted and really important was the lack of preparedness for the provision of home-based care. Certain high-income countries in particular with home-based care pathways have the possibility, these were not activated in countries like Canada, for example, but there was the possibility of having stay-in-place care for individuals who are fragile, have life-limiting illnesses, to not be transferred to hospital in the case where hospitals are really overwhelmed. The community-based providers we spoke with in countries that had these pathways for home care were extremely concerned. They regarded the pandemic response as hospital-centric and as talking about keeping some people out of hospital and yet not resourcing the community-based healthcare providers for what would be essentially this intensified need in the community for palliative care to individuals who might be seriously ill. So what are the implications for practice from that? There's guidance out there. We know what many have said should be provided for seriously ill patients triaged out of care. It does seem that those recommendations are really not happening in many cases. So there's a need to further troubleshoot the challenges of providing psychosocial supports to patients who are in isolation, psychosocial supports to their families, especially in recognition that that really impacts on healthcare providers' well-being as well. We also need to ensure that now, and some people had some ideas on that, such as, introducing Alexas to patients who were still conscious. They had seen that be effective for one case, and others were talking about creating more spaces for families to visit without having to don or doff. But as we end the study, we're really not certain how much palliative care is being provided and whether or not what is being called palliative care is actually palliative care or symptom relief. So that's a major area for further research. Back to you, Pat.
Thank you. The third finding of this study that we're going to focus on is the communication of critical care triage plans and plans for those triaged out of care. We found that differences existed about the need for and approaches to communication of triage guidelines that were linked to critical care. However, we did ask them about transparency in our interviews, and transparency and transparent communication was a common and consistent and important theme across all interviews and all regions that were sampled. Everyone had something to say about that. And this one quote is from a high-income country, but reflects the sentiment of many in that transparency is just as important as confidentiality, especially when it means life or death. So transparency means that something is easy to see or to perceive. And while that was a generally held value, so that was the term that was used, and an espoused value, there were significant variations with regards to how it was interpreted. Concerns were expressed about the content and the depth of triage information that should be offered, its timing, the authority from which it came, and the communication strategies used to disseminate it. There were particular concerns about the possible outcomes of being fully transparent. It was clear that the ethics of information sharing was weighing against the fear of inciting anger. Or as one participant in a low-income country worried, that transparency could trigger a social movement and uprising against the government. So how transparent should we be? In the following quote, you can hear the indecision about this. How much is too much? My gut instinct is that we should be trying to be as honest as we can, but maybe there were some consequences that I haven't thought through yet. I would hope that it would allow people to feel there's fairness in play in the decisions that we're trying to make as equitably and appropriately as possible. So there's sort of an integrity to the process, and I would hope that that would give people some degree of confidence. My fear is that it would also leave some people very fearful because it spells out the starkness, potentially, of triage decisions if we were to get to that point. And that from a high-income country. Many believed, with some exceptions, that critical care triage criteria should be made available at a population level, and that sharing resources up front would be a way to combat misinformation and avoid public anger. So even when transparency was valued, it was not clear-cut, and these shades of transparency reflect that there may be dangers, perceived anyway, in absolute transparency. So one participant, again from a high-income country where there had been some focus on advanced care planning at a population level, said, well, what is the best way to communicate the triage criteria? The need for advanced care planning conversations and planning. Booklets in an ICU or emergency room, they won't get read. Messages update on the web, I mean, I don't even get to read them. People seem to be getting most information from live media sources. And so in places where advanced or future planning initiatives have been part of the conversation like this, it was thought that sharing information about triage criteria and care could help citizens better prepare for possible illness and or hospitalization. However, clearly the approach, how you did that, was not known, despite many forms of media and messaging. And in one middle-income country where triage guidelines for elderly people with comorbidities were in place prior to the pandemic, it was considered unnecessary to publicize or make clear triage criteria for critical care. It was thought that most people who used the public system understood the system rules and that those decisions made by providers would not be questioned. And so this from a middle income participant says families and patients understand that those who are over 85 years of age with some advanced disease like cardiac, heart failure, COPD, so chronic lung disease, dementia, and cancer would not go to ICU, but to another floor where symptom care, so for instance for breathlessness, and palliative care would be provided. So triaging out of critical care was considered to be less of an issue where critical care resources were relatively non-existent or in great scarcity, and unequal access to care was an entrenched norm. And in low and middle income countries, participants felt that generally most people were unlikely to have expectations for critical care. So triage guidelines were irrelevant. And this would hold true unless people were of a higher class and could find ways to demand more. So in terms of being transparent, as guidelines and professional competencies encourage, we learned that transparency was a bit of a conundrum. How much, when, by who, how? So on one hand, in all contexts, there were concerns that triage information would instill fear and chaos in the population because resource inequities would become exposed. And one participant from a low-income country suggested that a legal opinion be sought to guide communication about triage protocols. Several expressed concerns about the way people would interpret triage plans. if an individual had a life-threatening illness, and particularly in settings where it was generally believed that under normal conditions, everyone had access to services. We heard from participants in high-income countries comments like this: the community is not ready for a triage document, which is ethically, politically, and morally distressing. And another said, I would say I'd want to be present and present it to the public, but I don't know how you do that without causing chaos and havoc. So on the other hand, some thought transparency could also decrease chaos and rumors, and there was a need for us to recognize that and to communicate that just because someone belonged to a certain tribe or religious group, that would not impede their access to care. And so transparency was was viewed as actually a way that you could demonstrate that there was equity and, as one said, prevent corruption. And so this heads-up approach was seen as a way to potentially increase citizen tolerance to triaging if it was necessary. So social media presented its own challenges to transparency, as this participant observed from a low-income country that was in crisis. They said social media is the main source of information for people and the government. They believe everything they see on Facebook and the news on TV. There is no reflection about it. COVID is just ICU and dead people, because that's what they see on social media. I don't know who has credibility. All they believe is what they see on social media. It's difficult to change their minds. And so this also fit with the concerns we heard about fake news and rumors spread by social media that would fill information gaps if information was too limited and not transparent. And that was not restricted to low-income countries. And so a central concern across the globe was managing misinformation, because rival stories and social media were particularly problematic. And in cases where resources were chronically scarce, one participant reminded us of the stress this placed on clinicians, but some sought solace in that other people were also experiencing shortages. And so this from a middle income participant who said, it's better we share all the truth with people. It's a hard time for the medical personnel, because it's hard to say to a family that in your case, we need the ventilator and we don't have it. But you know, they have the same situation all around the world. So this was invoked to get some sort of sense of community in their suffering or in their scarce resource allocation. And so despite this, people did agree that in some way and at some point, clinicians should directly share information. And as one clinician said, we need to own our decisions, believe in patients' and families' capacity to understand, and not assume a parental role. Okay. So communicating triage criteria on the individual basis to patients and families was valued by some, but raised concerns in others. So this is now moving from the macro to the micro level. And it was noted that particular relational skills were needed to actually engage in these conversations, to communicate about triage criteria for critical care. And there was concern about, again, around if you were transparent about it, that your communication may be misunderstood, generate anger. And so some people said, well, they really didn't need, again, to share it at all. And claiming that, well, the physicians need to make that decision. It's not about the family, whether you receive a ventilator. It's not something we necessarily need to communicate to the family. And that from a person in a middle income country. So a big fear was that people would be seriously ill and might self-triage themselves out of any care if they misunderstood triage critical care criteria. And so it was clear that if a guideline was disseminated to the public, people would need to understand how and where everyone could access care, even those who would not receive life-saving care. And attention was drawn to the crucial role of community health organizations, who also stressed that they had responsibility for triage communication, and it wasn't just for acute care. So what are the implications related to this for practice? Again, as I just stressed, around the avoiding self-triage out of any care, the need to develop and deliver messages with leaders in the community that the community trust. So those may not be people in the positions of formal authority, particularly in countries where there's great distrust and mistrust of the government and organizations. We need to be considering health literacy in general, and health literacy. If we aim for people to comprehend, to understand what we're saying, we really need to be thinking about the messaging. And then, as Elysée said earlier, the provision of education and training and support for healthcare providers to actually develop and sustain communication skills in these very stressful and challenging situations was very clear. And that concludes the presentation. So we'd very much thank you for your interest and attention, and we'll be very happy to take your questions and reflections. So over to you, Andrew.
Thank you for that very in-depth presentation. So now we have moved to the part of the webinar where we'll have a Q&A discussion. And as I mentioned at the beginning of today's webinar, you can raise your hand by using the clicking on the hand icon on your control panel, and we can unmute your microphone and you can ask a question directly to the presenters, or you can send in a question through the question tab, little question mark, and I can read that out loud to the presenters as well. So we'll give everyone a few minutes here. I do have a question, maybe to get things started. What responses, themes from your study here surprised you the most? Is there something that you weren't really expecting that you learned conducting this study?
I'll go first, and then Patricia, if you want to add anything. But I guess one of the things that struck us had to do with the guidelines and the confusion around the guidelines and possibility of committees. So just how nebulous for so many of the participants it was, the process, the stage at which the possibility of like these pandemic specific committees to support resource allocation decision making in their hospitals, for example. There was really a lack of clarity about what was going on in that respect for many participants. And that was obviously causing a significant amount of stress, because their response to what should be done and could be done was mixed up with feelings about what they might be asked to do without actually having something in front of them in many cases. So that seems like quite a significant finding in terms of yeah, not what we were looking for. Another thing that surprised us and that did not appear in this particular presentation, but there was some questioning of the need to develop and prepare for critical care resource allocation from some participants in 2 high-income countries. So the proposal was that the very discussion of resource allocation when it came to critical care for those participants was a political discussion that had to do more, that was unnecessary and it reflected almost a neoliberal dominant narrative that there's not enough to go around, when in fact in the minds of those participants there certainly was, and it's a question of getting yourself organized. So the whole premise of the study for them actually seemed to be buying in their view to this idea that it was inevitable that you would need this triage at some point in a public health emergency in a high-income country. And those participants were adamant that it was not inevitable at all. Dr. Strachan, do you want to add anything?
Well, I'm not sure that surprise would be the right way to describe, but I think I was very moved by and concerned about the stories, obviously, of people that really had no resources, and so in some ways this question was almost irrelevant for them, and so of course that reflects the inequalities and inequities in our world. So I think that many times our efforts are aimed at, have the assumption, I guess, underlying the guidelines that resources, are available in some way. And so what are clinicians to do? And I was struck by the fact they weren't used to this. They do suffer from not being able to provide what they understand to be needed care. The other thing that really hit me was all of the issues around transparency and what a conundrum it really was. And certainly, that's a word we use all the time. It's used to convey honesty, that you're not holding anything back, that you're being totally open. And this was a real issue that was quite interesting, actually. So how much do we tell people? When do we tell them? Will they know? What will they do if they really know? Etc. And then, so that's sort of at a macro level, the public, but then the micro. How do you take that to the individual person? And these are questions that need answered.
Thank you for that. And it's very interesting you mentioned the transparency conundrum, because we typically think of transparency as good, it leads to accountability. We hear it all the time, not just in healthcare, but politics and decision making of all kinds. So it is quite interesting you found that to be such a conundrum. I have a comment here. I'll just share with you. It's from Sean Smith in the audience. He says, strong and often overlooked work. Many thanks. And Tim Kirkpatrick, if you're listening, since you have a multi-part question here, if you would be so kind as to raise your hand, I can unmute your microphone. I think that might be easier to ask the presenters than me try to read through it, if you wouldn't mind doing that. We have a question here from Leanne Olson, and Leanne asks, it's actually a two-part question, asks, is there a plan for any follow-up with families whose family member was triaged out of care?
Mm-hmm. It's a really excellent, in terms of what we've identified as needing and meriting future research. There is that is definitely a piece that in this rapid study and working over the phone and Zoom, we didn't do, but we would be very interested in such a study, as well as with some patients who, of course, might be triaged out of care and survive. So they could also offer some interesting perspective.
Yeah, I would agree with that. Thank you for that suggestion. And I think one of the things I'd be very curious about was how that came to happen. And, I guess if I'm thinking back to your question before about surprise, and one of the things that kind of surprised me was that felt like in high-income countries, particularly where, you know, they were really in preparation stage, that people had sort of moved from this, you know, patient-focused sort of practice position to just one of like, it's like black and white, it's like page turned, as now we can't think about the individual, we're just thinking about the population, and how quickly that happened. So thank you for the suggestion. That's an excellent thought.
Mm-hmm.
We have an audience participant who has his hand raised, Donald, who I think, if I'm not mistaken, he's done a webinar presentation for WATM in the past. I'll unmute your microphone in just a second. There's a few comments here I'd just like to share. Excellent presentation was from Lisa Schwartz. Well done. And another comment from John Pringle says, thanks so much. I appreciate this presentation. So now we'll move to Donald here. I'm going to unmute your microphone. Are you there, Donald?
I am, yes. Thank you, Andrew. Hi, Elysée. Great presentation from you and Dr. Strachan. Thank you. So my question is around the existence of triage committees and other resource allocation guidelines, because I've heard of hospitals where they actually had those, but were not making those, not making it public out of fear for the types of reactions that might come from within the hospital staff or in the community from the public. And I wondered, how have you seen that sort of kind of balancing of those two concerns addressed in different places?
Thank you. I can start with this one, Patricia. So I think that we definitely, I think that that kind of lies at the core of at least some of the participants' uncertainty about what was going on in their hospital. They had a sense of, a couple of participants did have a sense that there might be some kind of actual concealment of the processes and formation and selection of committees within their hospital. And unfortunately, because whether it's accurate or not, we will never know, and I don't know if they will find out, but it was associated with historical tensions with administration or separation between administration and the frontline bedside providers. So one of the, even though that might make sense in terms of if there's a concern that with so many people working in a hospital, perhaps there's concern that if you start sharing that with all your staff and personnel, you know, then the wider community will know. I think that it seems from our study that trying to keep those developments out of sight from your very own personnel is equally extremely problematic. It's adding to stress, it's creating rumors, it's leading to certain assumptions that there is a separation between different levels in the hospital. And ultimately, you know, when there's a need to activate those committees, which ideally would be supporting the bedside staff, we definitely got a sense that there would be some, you know, there will be some pushback if those are not participatory. So that's quite problematic. So I think that when there's that kind of assumption that this is the best way forward, I would say that some of our findings are suggesting it might not be, because it's creating some bad feelings before committees or guidelines even get announced.
I would agree with everything you've said. I think the point about historical tensions is one that should be thought about. When we come to these situations, we come to it within a historical context. And so the way that people have been cared for in an institution as employees, the way people have practiced, the way things normally function, all of those things are what people begin with. So, you know, if leadership has been creating situations where there's mistrust, etc., that will become exacerbated. So I can see that it would cause alarm in staff, and as we have seen, we need the staff and we need to take care of them. So maybe that's an area in terms of guideline development. I don't know. One of the issues didn't come up in this, but in other work I've done is, around guidelines exist and then people don't have time to read them, and particularly in pandemics. So it's like this thing that exists out there, and so rumors can get started pretty quickly.
Does that answer your question, Donald? Thank you for it.
Yes, it does. Thanks. And it kind of reminds me of some of the debates in the 80s and 90s around whether you should tell patients the truth about their diagnosis. And we've thankfully moved on from that. And now we need to maybe have it around whether, administration should tell the providers all the truth. But thanks. Yeah, no, that was really helpful.
The other thing that makes me think about is specifically in high-income countries, many people enjoy a very relatively high standard of living or access to resources. And so this was a huge change in people's understanding of their world. So that happened, there was no preparation for that. And so I think that also increases the fear.
Thank you for that. We do have another question from the remote audience who would like to ask directly to the both of you. So I'm going to unmute Tim Kirkpatrick's microphone. You there, Tim?
Yeah, hi.
You have the floor.
Okay. Well, the first aspect that you talked about had to do with transparency of information. And obviously, from a number of different large-scale disasters, it's been apparent that the more we are transparent with what's going on and how things are being dealt with in the large sense, and the information you have about the nature of the specific disaster, relieves a great deal of anxiety and stops a lot of the speculation in social media. The other aspect of this that was your direct questions in the study had to do with the triage for resource benefits and for treatment in the population. And one of the big concerns that I can see with this has been that the elderly being the principal target, there are a number of people in the population who have been given the impression that they're kind of an expendable population. And overall, in groups, especially groups in conflict, removing any particular age group, whether it's youth or elderly, is disastrous for the long-term survival of the group that's affected. So using a triage technique that would say, well, they're going to be going anyway, that could be seriously disastrous. And again, that would create the example that you gave of people self-triaging. So my question comes down to, how do you address providing that sufficiency of triage to prevent that self-triage?
Well, there's the question of the day.
Do you want to go first?
No, go ahead.
Okay, just because you mentioned situations of conflict, and one of the things that is interesting is that I believe we had 14 low-income country represented amongst participants, many of them dealing with conflict or emerging or in a pause between conflicts. And it is in those countries that there was a sense, and these are the people who are responsible for implementing critical care resource allocation, that first of all everywhere, you generally do need to have resources to get into critical care. And even during a pandemic, this might not change in many countries. So that's going to be the primary determinant, and age is quite irrelevant in that sense. And the second sense is that, again, in those countries with conflict, the elderly across the board are seen as socially and culturally valuable. So in a conflict setting, and if we're talking about critical care allocation being culturally, contextually specific, which it has to be developed in accordance with what's available in a region or in a healthcare center, depending on what we're talking about. It has to be localized. And so it does seem from our research, which is small, but nevertheless, that there will be many scenarios where age will not be considered as something that should determine whether someone is in or out, especially because the elderly are not super elderly usually. They're 65, like those are the elders. And so one person talked about if that rare person makes it to 65 in my country, I'm not turning them away, because of COVID. It just doesn't make sense. And it doesn't make sense to develop criteria around a population that is so small in comparison to the wider population if we really have to talk about reserving resources. So it is not a major concern, except there's a sense that they may be given priority in many cases because of their high social value. So it seems like that question is more applicable and was definitely a concern amongst our high income country participants. And one did actually say that, to start having explicit talk of age-based cutoffs for admission to ICU, even in a pandemic, just reinforces a message that you are disposable beyond a certain age. And they were very alarmed at the message that goes out, which for that participant definitely echoes a wider kind of social marginalization and devaluing of the elderly in North America and Europe. So it's more of a problem of the global north, it seems. Does that help at all?
Thank you. Yes, that was exactly the area. There's conflicts in the third world countries of one nature, and then there's ones in the first world countries. And the one we're facing in North America and Europe and certain other developed countries is just that the economy is getting tight, and there's an attitude among the youth is get rid of the old because the youth are going to want to have the utilities and resources.
Yeah.
It's a societal issue, isn't it? It's bigger than COVID. Can I just make a quick comment? One of the things that you commented in your preface to your question was about learning from disasters and to be transparent. And I think that's an interesting comment. Those disasters that we tend to learn about are not in healthcare. They tend to be, the Challenger, big industrial accidents, airliners coming down, those kinds of things. In healthcare, we don't really have a history of transparency, even though that's an espoused value. So I think that's something that bears thinking about. And there are reasons people can rationalize why they're not transparent. So, but I think until big organizations model that kind of behavior, it's very hard on an individual level to do it too. And just a quick around triaging out of any care, I do think that's a significant concern. I'm not sure, what the answer is, except sometimes when people talk, they say, oh, there's nothing they can do, or there's they can't get care, or triaged out of care. And so my hope would be that you're not triaged out of care, that you get care. But there is this sort of sense, I think, of abandonment, that if you can't have access to critical care, that you get nothing. And so that's certainly messaging that needs to be considered.
Great, thank you. And thank you, Tim. I know I put you on the spot there to ask the question out loud, so appreciate that. We have 2 more questions. Do we have enough time, Elysée and Patricia, to take up 2 more questions here?
I'm okay with.
Yeah.
Okay, so these are both ones that were just sent in through the chat. Question from Saminda from Sri Lanka, I believe. Actually, I think I met Saminda in Brisbane last year, or at the Wadham Congress, and he asked, who does the triage? Is it different between high-income countries and low-income countries?
Good question.
That is a good question. I think it would be medical staff would, we didn't, I'm not sure that we really had anybody that had done that yet. But mostly, so this is interesting. So at an acute level, within a hospital, physicians were very concerned about individual responsibility for that, and so there was a spoken need for committee decision, that it wouldn't be one person making those decisions, and that is where guidelines actually were a relief to people, that they weren't just making it up or being mean. So I think that would be the case. However, I wonder about in the community, for instance, in long-term care homes, nursing homes, etc. About that, because decisions would then be made around transfer to acute or critical care. So I don't know the answer to that, and it's a good question that you're asking.
Yeah, and it is very complex. I mean, normally it would be, from what we heard from our participants, who were operating often without, only 19 of the 52 were operating with those guidelines present. So a lot of them were still operating as they normally do, which is the intensivist is the one who's kind of assessing whether somebody is prone to benefit from an intervention, or that might be referred to them by a colleague. But there certainly is also the added complexity that if the person who needs the intervention is of any importance, they will be, even if it's the only ventilator in the country, it will be transported to that person of importance. Or if somebody of importance shows up and needs to be helicoptered somewhere else in a country of low resources, that will happen. So there's also this trumping of triage plans by systems of power and economic inequality in many settings. So, who is doing the triage? Well, there's more than one level.
Thank you for that. And we have one last question here, and I think we'll wrap it up as we are about 20 minutes past the hour. And I just want to thank everyone who's stuck on the call here and stayed around with us. We have the majority of the participants still on the call, so that's really exciting, encouraging. And this one is really shifting gears to social media. And the question asks, the person is asking, I wanted to know your opinions in regard to policies put in place by social media platforms. Many social media platforms adopted policies that remove false information in regards to COVID-19. Do you think this was a right step?
Do you want to comment on that, Elysée, or?
No, go ahead.
Well, I'm not sure what my position is on that. On one hand, I think that it was a good idea. And on the other hand, I think that it worries me about who might make those decisions. And, it's like the free speech that we value. So I don't know what the answer is for that. I think even in the absence, when things like that happen, actually, it may serve to make some people believe that, in fact, information is being withheld. Well, it is, but let's say it's false information. But, you know, that actually may perpetuate rumors and mistrust. I think these are big questions around social media, and ones that we haven't really got our minds around yet in healthcare as to, you know, how they can actually work best, certainly in situations like this. There's lots of, you know, good examples, but also equally concerning. So I don't know the answer to that, but I think it's a real, it's the swamp to wade in.
Yeah. And I would just add what we all know, which is how different it is from context to context. I mean, there are certain news sources that are trusted more than others, for example, in Canada. So even if there's other messaging going on, people are referring to certain sources. Quite a majority are, and they're more trustworthy. But you go to other countries where there's no nationally recognized source of media that's reliable or perceived as reliable and trustworthy. How do you regulate anything? I mean, the official messaging from government, for example, is not trusted in a lot of countries.
Yeah. The other issue also that, you know, the other side of social media in terms of this, in the one case where one participant was telling us about, you know, people very impoverished and malnourished and, you know, in conflict, and yet we're watching these dramas unfold in other countries via their social media. And so, you know, how much do people, you know, when they watch, think, oh, that will happen here, or that this is what's going on. So there needs to be some critical discussion, I guess, around this whole issue.
Yeah, it's a great question. Thank you.
Yes, I think that could be the topic of its own webinar, or probably series of webinars.
Yeah.
Well, with that, I think that is a good stopping point here. That looks to be the last question. So I'd really like to thank Patricia and Elysée for taking the time today to share their research, share their knowledge, their insight. Any parting words before we sign off here?
Just thank you so much, everybody, for joining us, and thank you very much, Andrew, for giving us this opportunity.
Yes, thanks so much. Be well and safe, everyone.
Mm-hmm. Yes.
Thank you, and it was my pleasure. It was really enjoyable putting this all together. Well, thank you, everybody. We'll let you know by email when this recording is posted online, and we'll let you know of upcoming events by email as well. Have a good afternoon, morning, evening, wherever you are in the world. Bye-bye.
Bye-bye.
Bye.